So, hello, it's a pleasure to talk with you. My name is Alasdair Parker. I'm a children's neurologist based in Cambridge, and I'm only sorry to miss you all in face-to-face today, but I'm hoping this pre-recorded talk may be helpful to you. I'm a busy acting paediatric neurologist, and it's been a pleasure to support families which with conditions which I think are challenging in the early part of children's journeys. So just a few terms for you. Symptoms are the problems that your child or young adult is having rather than the underlying diagnosis. So what I'm talking today is about things like difficulty sleeping or vomiting or eating, as opposed to the specific leukodystrophy that they've got. So I'm going to icebreak this by talking a little bit about an initial presentation to a GP. So a child might be referred through to a GP and then on to a paediatrician. Possibly they've lost skills and the parents have found them not quite right. And hopefully there will be a prompt onward referral and diagnosis. And I think this weekend you'll be hearing more about how we've improved that journey in the UK. But we all know there can be a considerable delay. And one of the families affected by leukodystrophy has kindly allowed me to show a picture of their two boys who were affected by this process. And this is just before they became, the leukodystrophy became active. And you can guess where that is. It looks like Euro Disney. Unfortunately, the leukodystrophy can progress rather rapidly, can't it? And we can see on the next picture, which is an MRI brain scan of the bright white areas, which show that the brain has been affected by one of these processes. And what happens then is we push on to diagnosis, and this may involve a number of different parameters: blood tests, MRI scans, and specialist assessments. Genetic tests will identify many of the causes these days, but we often need metabolic tests of biochemical balances, and then a diagnosis will be delivered, possibly quite quickly now, and this is likely to be rare and frightening. And that's a point when families will possibly get a lot of different people contacting them. And if you just think yourselves about the people who might have contacted you once the diagnosis was made, I thought about the GP and also the local paediatrician, who so often is missed in this journey, as I found that both families and we as specialists get a bit taken up with what happens at a specialist centre, sometimes at the expense of simple things that can be done locally. Therapists may arrive, hopefully quickly, but we'll talk a little bit later about how that can be a bit slower than it needs to be. And just think of yourself about the type of therapists who might be involved with your child or young adult. I can think of physio, occupational, and speech and language therapists. But there are other people who come in, sometimes with not such a label, such as play therapists can be really useful, often coming out of hospice services. And psychotherapists as part of the psychology services can be invaluable. We may get radiologists looking at the pictures. Neurologists such as myself are often involved. And I feel in my centre, I've often seen that other people might step out of the equation once our team are involved, at a point when it's very important that the other specialists and local workers are involved. I thought about endocrinologists and more, and you may think about some of the other people involved with. Our experts in metabolic medicine will be a good example, as well as the genomicists. And it can be pretty confusing, can't it? Being unsure as to what everybody is doing in this package when you haven't really been exposed to specialist paediatric services previously. So what we need to do is build a team around the child. And I'm wondering whether you can stop and think a little bit about who you think should be in that team. Maybe you're at the beginning of your journey or quite experienced in this. Who do you think should be in? Who are the most important people here? Well, for me, by far and away, the most important people who have the greatest insight and ability to really improve a young child's or young adult's quality of life will be the parents and the main carers. And you need to stay central in this journey. And there's some other people who often get lost, but the GP can be very useful. For example, if the child's on regular medication, that will need to come from the family team. And the local team have resources as well. A good example would be the health visitor, who can be very useful for younger children and integrate with special needs health visiting until children are quite a lot older. Now, this is a point that I really want to emphasize, that the main coordinating paediatrician is critically important. And if they're not identified, I think it leads to a poorer standard of care. And almost invariably, they're not someone who works in a specialist unit, such as Cambridge or Great Ormond Street or Birmingham Children's. They're the people working in your local centre, in your local district hospital. So for an example, in East Anglia, there'd be people working in Luton or Stevenage or Norwich. And often the best person to take this role is a community paediatrician, because they're integrated with the therapists. They're very good at dealing with development. And many of the symptoms, the problems we see, are things that they deal with routinely. I mentioned the therapist, and in little letters, I put people such as myself or other specialists, such as genomic specialists and metabolists. So I said earlier that symptoms are problems. What I can say is almost no problem is specific to a leukodystrophy. Almost all the issues you have with things like sleeping and feeding will be seen very routinely by local multidisciplinary services. And yes, they can certainly be a challenge, but it's likely the services will have had almost identical problem, the same challenge, and solved it successfully in other children. So I'm going to run through a few, and I rank these. Sometimes I give this talk in different times, and over the years, I've decided just to put sleep first, because I think disordered sleep is one of the most challenging things for families caring for children with neurological disorders. And they need it, but you need it as well. So we need to make sure that the whole family and team around the child. So the first thing to say about sleep is that community paediatricians deal with children with sleep disorders completely routinely. And they can do something called a standard sleep assessment when we look at something called hygiene, sleep hygiene. So things that make the sleep better, things that may make it worse, and have some simple therapeutic tools that might help. So, for example, if your child's in a nursery placement, keeping them awake in the daytime so that when they get to your house in the evening, they can get a good night's sleep. And yes, you're going to see those little things at the bottom in italics in these slides are areas that I felt over the years get too much emphasis. So my own experience is medication in isolation is unlikely to help sleep. It needs to be a number of factors. And although drugs such as melatonin, which initiate sleep, can be really helpful, on its own, you're probably not going to solve the problem. Eating can be very difficult because the swallowing muscles can be affected, and often children may need to eat a diet that's appropriate for a younger child. So if you're having difficulties with things like liquid, clear fluids and meats, then we might go back to what you would have fed a child when they're 18 to 24 months, which might be pureed foods and even thickener in drinks. So we need to watch their weight really carefully. And we may need to get specialist support from people such as dietitians, speech therapists, because they actually do the swallow also. Some children benefit from having a tube through the nose initially into the tummy and occasionally directly into the tummy, where they can have some high-calorie supplements, which allows them to feed in a more relaxed way orally. So we're not looking to stop oral feeding in any child with leukodystrophy. We're trying to support that. But for some children, some tube feeding will be helpful. And your local secondary paediatricians will have a lot of expertise in that area. Oh, look what I've written at the bottom again. Medication in isolation is not the answer. Movement disorders, and this is a young man whose mum's kindly given me permission to show the slide. And as you can see, he's flexing his arms up because they're rather stiff. And one of the questions we need to ask is, children, are they developing what we call spasticity or dystonia? That really is posh words for stiff limbs. And dystonia is a good example of how parts of the brain, other than the white matter that's affected in leukodystrophy, can also be infected. Because dystonia comes from an area in the brain called the basal ganglia. And it's very common for children, despite the MRI saying it's mainly in the white matter, for the process to also affect other parts of the brain and give them stiffness in the limbs. We can get good support for that. This is normally primarily driven by negotiations between the carers and the physiotherapy, but also occupational therapy, who supply things called orthoses. And that's equipment the child may use. And here you have a lad who has leukodystrophy, who's got specialist equipment you can see with a specialist seating and neck control, and we'll have a number of other things in the house. I think I can see a sling there that allows him to be hoisted and transferred. So all these types of equipment are things that the local team very routinely support families in. And I'm afraid I'm not going to apologize for my italics at the bottom to say, although medication can be really useful, and I'll mention one or two things at the end, in isolation and emphasizing that, it's going to be produced suboptimal because control of stiffness, because I heard a very good quote from Dr. Martin Smith in Birmingham and now Oxford many years ago to see medication treats some children somewhat, but these other strategies I've mentioned will treat all children, and although they may not cure the stiffness, are likely to help in the great majority. I mentioned the word orthoses and orthotics, and that's just a posh word for equipment. And we can get plenty of support for equipment, from simple things that you may use like toys to more sophisticated things such as seating, and all the way through to adapted vehicles, electric wheelchairs, and in the house, hoisting equipment and things like that. Now, visual failure is something that's hardwired into my experience of children with leukodystrophies, and in particular adrenoleukodystrophy, because often that's the first thing that goes off and can lead to disability and distress. And again, thank you so much for this photograph, permission to use this photograph, which shows a lad who's in the early days of leukodystrophy, but he's very distressed at times because he's lost his vision. But this dramatically reduced when we gave them support, and particularly got him out walking. And although I think you can see his leg position would supply some dystonia and spasticity, but getting him out the house and his level of distress has greatly reduced. So early referral through to visual impairment teams, because there are whole teams of specialist nurses and therapists working in the community who I found have been some of the most reactive and helpful of all the therapy teams. And they're a good example how they can interact with other people, such as teachers, doctors and orthoptists, which leads me on to the importance of working with specialists within the mainstream sector, initially special needs coordinators, who have this funny word, SENCO, as well as other specialists within the educational sector who may help with an educational healthcare plan, or even specialist educational units, which can be really supportive and helpful. Once more, they may not have heard of the leukodystrophy that your child has, but they will certainly have cared for children with the same type of disorders. Distress and confusion splice in together, and identifying it is really important. And actually, you treat it as you would do for a very elderly person who's a bit confused. Avoid sedative drugs, because the drugs that sedate you are just going to make you more confused. Although we do use sedative drugs, such as chloral and morphine, for some children, with leukodystrophies, we have to use them incredibly sparingly and carefully, because we know that things that make you more sedated make it more difficult to think. And if you're finding it more difficult to think, it'll be more difficult for you to understand the environment around you and how these slightly scary people, such as myself, are actually trying to help you. So thinking about that axis can be really helpful. I mentioned medication previously. Irritability can be an issue. And so many times when I've reviewed children, there's been a request for medication. But once more, coming back to it, it works poorly in isolation. And thinking about some very important axes we can take and complex actions, as a good example would be whether the child is having difficulty swallowing and is therefore hungry. Are they in pain because they've got a sore bottom or hips? Are they bored? Nothing against us as paediatricians and you as carers, but children like a lot of different environment. So is this child stuck at home because the school are finding it difficult to accommodate? And do we need to support with things such as school, support you as carers, thinking about respite? And that feeds really well into multidisciplinary discussion. I've only got a few minutes more, so I can't summarize how to optimize multidisciplinary discussion. But what I would say to you is that this whole Zoom factor, these remote consultations, make it much easier. And now it's very easy to pin down a therapist or a pediatrician and get as many people together at short notice. So coming back and thinking about the child, there are specific conditions that may affect specific disorders. As an example, epilepsy, but remember that's best managed at secondary level because there's nothing specific about the epilepsy we get in leukodystrophies. And every district hospital has an expert epilepsy nurse who splices in with a local epilepsy specialist and will get third level, i.e. tertiary support from a unit such as I work in Cambridge. And there are many other specialists who could be used at times. Joint problems and stiffness, our orthopedic team can be helpful. And the gastroenterology team, the feeding and stomach teams can be really helpful. Social care is some part of the journey which I think is essential. And many parents have expressed to me over many years how difficult it is to get engagement. But they engage with the elderly really easily. So I think we just need to push that door open a bit more assertively. And early engagement allows us to get things such as disability and mobility allowances, as well as care assistance. And one of the issues that does come in regularly is respite care. But for many parents, they feel uncomfortable with a child being cared for away from the home. So one middle ground where children can get a lot of support and parents can get a bit of time out so they can always organise the other things in a child's life is school. So I really emphasise the importance of getting children and keeping children in school. So coming back to this talk, I've got about another minute or so. The building blocks are the family, the local multidisciplinary team. And I've run through an awful lot of different names and specialists and apologise if you don't remember them all. But those members of that MDT will know all about those people and be used to working closely with them. We specialists will come in to help with key problems. And as an example for neurologists, we will be maybe useful in doing things such as stiffness, seizures and distress. And we might also be good at telling you where you're going on your journey, as you may not know and the local team may not have heard of the condition. So we can educate the multidisciplinary team around the journey. P.S. I've been a bit down about medication, haven't I? But it can be really helpful. And I'll give a few quick bullets. Drooling can be helped by medication called glycopyrrolate, which makes the secretions a little bit less voluminous. Stiffness, I mentioned baclofen, but there are also some other really useful drugs there, such as clonidine. Sleep initiation, but not maintenance of sleep with melatonin can be helpful. Seizures with all the medication. And gosh, I realize I made an error because I didn't include constipation anywhere in this talk, which can be a big problem. If you're not ambulating, walking around regularly, you can get a bit bunged up. So using medication to keep the bowels movement, and the drug we generally use for that is something called Movicol, can be really helpful. I've suggested watching out for inflation with drugs, though, and that's where you have a relentless increase in the number and dosage of drugs, which can lead to all sorts of difficulty managing them. So being as parsimonious to being as stingy as you can with the number and dosage of the drugs is a good, not a bad thing. But using them appropriately, of course. One thing I would counsel you to do is have a think about what the target of treatment is. And if you don't achieve that, reduce or stop the medication. So in summary, it's been a pleasure to have a interaction with you, and I look forward to joining you in family weekends in future. So build a team, but there's no hurry. We do want the family and local services centrally, and we do want the local paediatrician who should be able to identify, assemble, and empower the team who will support the family. Use key professionals judiciously. Medication can be really useful, but rarely in isolation. It needs to splice into this multidisciplinary working. But be careful about drug dosage and number inflation. I hope you've enjoyed listening to this.